All right. I'm finally up and ready. I thought when we got back to in-person teaching, we'd be done with all this, but apparently we are definitely not. There we go. Okay, finally. Okay. See if I can hide this a little bit. I don't know if I can hide this. Yeah, I'll hide it when I get to the bottom. Okay, so we finished off. We had talked about all the vocabulary we talked about. Then we got into red blood cells, white blood cells, platelets, and then I went over red blood cells, and this is where I ended it because it was a long day. So we are going to have, like I said, a blood physiology lab. It's basically a blood typing lab, right? But so we're covering blood today. So vocabulary, again, sorry about this. Try and keep moving it. Get away. Ooh, here we go. So vocab, this part of the chapter 7 is all vocab, no pathways. Polycythemia versus anemia. Well, you're going to usually be more concerned with anemia. So polycythemia means higher than normal red blood cell count. Well, how do you know? Well, you can take blood, send it off for a chemistry in a panel, but you can do it really quick. You can actually draw a little bit of blood. We used to do a lab where we did this. Put it into a little glass capillary tube and spin it in a centrifuge. And the heavy things go to the bottom, like the red blood cells, and then the clear plasma floats to the top. And then you can hold that capillary tube against a chart that will tell you what percent red blood cells they have in that sample. And then there's standards for men and women, and you can tell if someone's got higher than normal red blood cell count and then a lower than normal red blood cell count. Polycythemia, if someone has that, it's usually not pathogenic or a disease or anything like that. It's usually because the patient's dehydrated. That's all. All right. So that the water content of their blood, the plasma layer, is kind of small because they're not hydrating enough. Now, anemia is usually something. Now, in women who menstruate, that can be simply, oh, are you having your period this week while we're taking a sample? That certainly could be the reason why. But if it's not in that time of their menstrual cycle, then there could be something going on. So anemias are very common. Let me check my clinical app to make sure it's working. Give it a second here. Oh, okay. It's thinking. There we go. All right. So we're going to talk about 4. They've got 3 here. Iron deficiency. Ladies, you've probably had times when your iron was low. It's usually associated with having a menstrual flow. You're losing red blood cells and the iron that's part of the heme part of your blood. And so that can be that. So don't freak out if your iron is low. And the thing is, if people do have chronic low iron, you can take supplements. It's easy to fix. And then we'll talk about these 2 as well. All right, so that's working. That's great. Let's move this out of the way. Okay. Okay. So iron deficiency, low iron in your diet. I will add low iron in diet. Oh, come on, pen. Or blood loss. Okay. And that could be as mild as just having a menstrual period and losing those red blood cells. Now, pernicious anemia. Again, it's kind of, you can take supplements. So if you don't have enough vitamin B12, or you have a condition like maybe Crohn's disease or irritable bowel syndrome or something digestive going on where you have a lot of digestive upset and you're not absorbing the nutrients like you should be. You might not be absorbing enough vitamin B12, which you need to make those red blood cells, but they're supplements. So easy fix. This one, not as much of an easy fix. Aplastic. So plastic refers to growth, like plasia is growth. And A means what? Absence. Okay. So in this case, it's absence of enough red blood cell production. So it could be a problem in the bone marrow. If someone's receiving chemotherapy treatment, you're given a pretty toxic cocktail of drugs that target rapidly dividing cells, cancer cells. Cancer cells aren't the only rapidly dividing cells in your body. I told you your red blood cells only live about 120 days, and then they're broken down and recycled. More are being produced every single day. So if you're taking chemotherapy, red blood cells are rapidly dividing cells, and it's going to slow them down. When we get to white blood cells, people who are taking chemotherapy are immunocompromised because white blood cells are rapidly dividing cells. And so that's what chemotherapy does. Do I need to write that down? Chemotherapy targets rapidly dividing cells. Anyone want me to write that down? Is that kind of generally understood? Would you like me to, JD? Okay, all right. Chemotherapy kills. I don't know if this will bleed into the next vocab word. But for you, you can write it off to the side. I don't have much room to write anything off to the side, but that's what chemotherapy does. So that's why when you're taking chemotherapy, your hair falls out, your hair follicles are rapidly dividing. You have stomach upset because your intestinal lining sheds itself and replaces itself about every 3 to 5 days. Rapidly dividing cells. So chemotherapy will hit all those things. That'll explain some of the symptoms that you see with people who are having that. Renal anemia. I remember I talked about the liver and hormones because the liver does produce hormones. And I said it produces erythropoietin. And then on that slide, it also says the kidneys do. Erythropoietin is, erythro, and I did this in the endocrine slide, means red. All right. That is a hormone that stimulates red blood cell production in your bone marrow. Okay. And by the way, the reason that I have these images here is the long bones of your body, like your femur, your humerus, your radius, ulna, even your pelvis is a good place where you have spongy bone. Remember this from anatomy? Right, you have cortical bone and spongy bone on the inside, and it's spongy because it looks like this. Well, in that bone marrow, the spongy bone, that's where your blood cells are produced. Red blood cells, white blood cells, platelets. And if someone has anemia and looks like it's bad, not like, oh, you had your period, or oh, you're not taking enough vitamin B12 or iron. Like, the bone marrow is not working to make enough red blood cells and you're not on chemotherapy. Got to find out what's going on. So what is this procedure that is being done right here, where you get someone on the table, they curl up into a fetal position so the wing of the ileum is really close to the skin, and then you tap that with a big old needle, big old long needle. It's not a spinal tap. Anyone? They are going into that spongy bone with a long needle. They got to go through the skin, past muscle. They got to punch through the cortical bone right here and get in there. Not a very comfortable thing to have done. They're basically doing a bone marrow tap, all right, or biopsy, bone marrow biopsy, because they want to find out what's going on in that bone marrow. Why isn't it working? Could be cancer, could be something else, all right? So this is a procedure that you will see when you're in nursing. Okay, if they suspect low erythropoietin is the problem, they can simply do a blood panel and look for that hormone. And then this one I will spend more time on a little bit later. But autoimmune, what does that mean? Immune attack on self, on your own tissues. Your body's not supposed to attack itself. It's the immune system's gone haywire somehow. Hemolytic means red blood cells being destroyed. What are they being destroyed by? Antibodies that your own immune system is producing against them. Okay, this doesn't usually, bless you. Need a tissue? No. This doesn't usually happen to people. It's not a common thing, but there is a common situation, very common, you'll see it, where a pregnant woman carrying a fetus that has a different blood type than her, that can happen. Very, very, very common. But I have a slide that talks about it more, but it's basically called RH disease or disorder. It's not really a disease. It's just a genetic incompatibility with antigens on blood cells. That's all it is. Okay, but very common. Any questions? Okay, blood typing. All right, we're going to be doing this lab, and it's so quick. You can blood type yourself in 3 minutes. But the hard part is getting enough blood to put on the 3 little testing wells. All right, so yes, you will be using lancets again, but it'll be the last time. It'll be the last time. All right, so you should know how to do blood typing. Easy peasy, lemon squeezy. All right, and why would you blood type someone? Let's say someone comes in and they're bleeding and they need a blood transfusion. You have to know what, if it's not on their chart. All right, what if it's a patient you've never seen before? There's no record on them. You don't know what the blood type is. You got to find out, because then you'll know what blood type they can receive as a transfusion. Okay. Okay. So we have the ABO antigen for human blood, and we also have a RH antigen for human blood. Animals are different. So we have basically 4 blood types based on the ABO system. And if you're RH, if you have the antigens for the RH factor, you're RH positive. And that comes as the positive after the ABO. If you're negative, then that's the negative that comes after the ABO system. So a blood type A, that person has A antigens. That's why they're type A. They have a cell marker, A antigens on their red blood cells. That's what makes them A. But they'll have also anti-B antibodies. So their body has produced antibodies against B-type red blood cells. So they can't receive any type of B blood because their antibodies will attack it. The antibodies will cause the red blood cells to agglutinate or clot. That's a thrombus. And what could happen from that point once you have a thrombus floating in your circulatory system? You could have an embolism. It could go to the lungs. It could go to the brain. It could go to the heart. It could go anywhere. But if it goes to the lungs, that's pretty bad. You saw the video, right? Huge clot coming out of the pulmonary artery. All right. So they can only receive type A or type O blood. So for persons type B, they're B because they have B antigens on their blood, but they'll make anti-A antibodies. That means they can't receive any type of blood that has A antigens in it because you'll have the clotting, the thrombus, the embolism, yada, yada, yada. Not good. So they can only receive, touch the screen. They can only receive type B or O blood. Now, if you're AB, you have both those antigens. You have A and B antigens on your blood. And you have no antibodies. Yay. Okay. You can receive any old type of blood they have on hand. All right. So you can receive A, you can receive B, you can receive, of course, AB, and then O. So any old blood will do. We do have to monitor the RH thing, but that's why you're called the universal recipient, because you don't have antibodies. There won't be an agglutination reaction to the A, the B, the AB, or the O. If you're blood type O, you have no A and B antigens, right? But you have anti-A and anti-B antibodies, sorry. So your blood has no antigens on it of the AB system, no antigens, but you have antibodies in your body that would attack A blood, B blood, or AB blood. So you can only receive type O blood. Can't have A, can't have B, can't have AB. You'll have agglutination, you'll have a clot, you throw a clot, bad. All right. Now you're like, oh my God, type O is the most common blood type in the human population. There's usually not a shortage of it in blood banks. Okay. So don't worry about that. The most rare blood type is AB. However, you can receive any blood type. So it all balances out, right? Okay. Now, let me move this so it's not in the way. I just do this. Yes. Now the RH, if let's say you're type A and you're positive for the RH antigen, what you're recorded as is A positive. If you lack the RH antigen, you'd be A negative. That's where the positive and negative comes in. Now, having the Rh factor is the more common situation. 85% of the population and only 50% are Rh negative. So does Rh factor or antigen on blood matter when you're giving a transfusion? Yes. Okay. If you have I'll just stick with type A. If you have a type A negative person, they must receive A negative blood or O negative blood. If you give them A positive blood or O positive blood, you're still introducing to their system an antigen that this person's body hasn't seen. And they within about 2 weeks of that transfusion, they'll have made antibodies to it, and you could have a clotting event. All right. So yes, you must match the Rh to the person that you're giving a transfusion to. Okay, so let's do this. Okay, so here we have a typical blood typing card. This is just like our test. We have 3 wells. We have an A well, a B well, and RH well. Okay. So this is just plain blood that isn't reacting to anything. This is blood where obviously an antibody is reacting with an antigen that's present, and it's causing agglutination or clotting. The blood cells are forming a clot, a thrombus. Okay, that's a reaction. So if you are type A, okay, you're type A because you have A antigens on your blood. In order to determine what blood type that person is, you put blood in the A well, the B well, and the Rh well. And then you put anti-B antibodies that were synthesized in the lab in the A well, anti-B antibodies in the B well, and anti-Rh antibodies in the Rh well. You're providing antibodies. If the antigen to which those antibodies were made against are present, you will have a positive reaction. And so you know, oh, that person has type A blood. But when you put B antibodies in, it didn't react. So there must not be B antigens on that blood. So they don't have B. If they have a reaction in the Rh well, the antibodies are reacting to the Rh antigen, which must be present. So they're Rh positive. So that makes it A positive. Okay. No reaction in the A, reaction in the B, reaction in the Rh, you're B positive. Reaction across the board. They have everything. They have A, they have B, and they have Rh. If no reaction across the board, oh, that says, oh, it does make me feel better. They don't have A or B antibodies. That makes them O. And if they don't have Rh factors, that makes them O negative. All right. So that's how you're going to do the blood typing test. Very, very easy. All right. Does everyone understand? The whole antibodies are reacting to an antigen that's present on your blood, or maybe not present. And that's how you tell the blood type. Easy peasy lemon squeezy. Okay. I say that because I got fresh lemons in my tea and it makes me so happy today. Okay. Rh incompatibility in pregnancy. Very common. Okay. This is something that a good OBGYN will go over with a pregnant woman before birth or, early in the pregnancy, family history, things like that. So if a woman, let me move this again, sorry, down here. If a woman is Rh negative and her significant other is Rh positive, there is like a 50% chance that that child, that fetus growing, could have Rh positive blood. Now, usually this is not a problem because mom's bloodstream and baby's bloodstream do not mix. The placenta that goes down to the umbilical cord, okay, that placenta is basically communication between mom's body, but not red blood cells. Red blood cells don't cross, white blood cells don't cross, cells don't cross, at least not blood cells, okay? Oxygen, CO2, glucose, proteins, all those goodies do get across by osmosis, the placenta, all right? Baby's bloodstream, blood cells can't cross that placenta to mom's body. But sometimes during childbirth, there's problems, okay? Sometimes a woman has a C-section, cut through her and they take out the baby. There's always the chance that baby's bloodstream could touch mom's bloodstream, okay? If it's a difficult birth, if they use tools to extract the baby, all right, the tongs, or if they do a lot of manipulation with their hands, like if the baby's in breech position and they kind of have to go in and reposition the baby. Yes, you can do this. I've done it with goats that were breech. I've done it with goats where the babies have one arm tucked behind them. You have to go in there and bring it forward. physicians, PAs, they have to do that too sometimes during birth. There is a chance a small tear in baby's skin could mix with mom's bloodstream. Now, if that baby's Rh positive and mom's Rh negative, mom's body has now come in contact with an antigen that her body's not seen before. And 2 weeks down the line, because we know when you're exposed to an antigen through vaccines, 2 weeks is the bare minimum, maybe 3 weeks, your body will start forming antibodies. Once mom's body starts forming antibodies against Rh positive blood, antibodies can cross, all right, that placenta. So mom's antibodies could, for her next child, if it's Rh positive, her antibodies could cross the placenta and start destroying the baby's red blood cells. Certainly when the baby, if the baby makes it and is born, her breast milk, in fact, the first breast milk colostrum is packed with antibodies. And if those antibodies contain, if those antibodies go into the baby's body and attack the baby's red blood cells, that's bad. Okay, baby's only got a finite amount of blood supply. All right, so that is the problem. Miscarriage. Miscarriage is very common, spontaneous miscarriage. Right? My mom had 2 miscarriages before she had me. All right, she had 1 before she had my brother. All right, almost up to 30% of women will experience a miscarriage. Her body reabsorbs that embryonic tissue. And in reabsorbing it, if it was Rh positive, wow, her body just reabsorbed that and became exposed to it. You see where I'm going? That's how it happens. Okay, so since it's so common, all right, go ahead. Why aren't you going forward? Okay, mom's immune system, if exposed, would develop antibodies within 2 weeks. And then the next pregnancies, once you've got antibodies, they could be there forever. They could be there forever. So we got a problem, all right? It's called autoimmune hemolytic anemia. So autoimmune is it's an immune attack. And the hemolytic that destroys, lyses them, red blood cells. And that's where the anemia comes in, is because you're losing red blood cells. The baby is losing red blood cells because mom's immune system is attacking and destroying them. So, okay, what they do, and I have a clinical app, and let's see if that link is working. So let me now move this out of the way. And it is in page 129 of the text if you want to read what they have to say. Come on, clinical app. Wakey, wakey. Ooh, that's very small. Okay. It doesn't harm the mom, okay, because she doesn't have the antigen on her red blood cells, so the antibodies aren't doing anything. But it is a problem for the next fetus that might be Rh positive in her body. It's also known as multiple names: autoimmune hemolytic anemia, erythroblastosis fetalis. All right, erythroblastosis, destruction of red blood cells in the fetus. All right. This can be prevented by injecting the Rh negative mom with an antibody known as RhoGAM, antibodies against the Rh factor. Now, this is counterintuitive. Why are you giving the mom an injection? The baby's the problem there. The baby's on the risk of anemia. That doesn't make sense. What you're doing is, and now they're starting to do it prophylactically, certainly in a mother who knows Rh negative that could have an Rh positive child. They give her an injection of these antibodies so that if any fetal red blood cells with the Rh factor got into mom's body, that injection of antibodies will find them and destroy them, okay? Before her immune system has time to detect them and form antibodies. So attack those red blood cells before her immune system finds it and starts the process. Because once you start the process, there's no going back from that. Does that make sense? Did I explain that enough? Comes across? That's why you're giving that mom that injection. And that's certainly what nurses are going to be doing. All right. Okay. Let's go back from that. Okay. So basically it's a preventative thing. Prophylactic means prevention before you've got the problem. So if they suspect she's been exposed to Rh positive blood from the baby, give her their injection of this. Okay. It says anti-D, that's anti-Rh, called Rho. Immunoglobulin monoclonal antibodies. Okay, we're probably familiar with some of this language from all the COVID vaccine stuff. Okay, so destroys any Rh positive red blood cells in mom's body to stop her immune system forming antibodies. Okay, was anyone familiar with this before I went over it? Did you have a question? Yeah. Yeah, so they can know that just by testing amniocentesis while the baby's still in the mom's body. They can find out. They can find out the baby's sex through karyotyping. They can find out all. They can look for certain diseases, genetic defects, whatever. They can certainly probably get some fetal red blood cells. But certainly after birth, they could. There's a whole litany of tests that's done on a baby when it's born. Okay. The baby comes out. They give it to mom. Oh, okay. Now we got to take the baby and do all these tests, right? So just check for those kinds of things. Yes. White blood cells. So in our lab on blood physiology, you will be identifying white blood cells. Not something that a nurse is going to do on a regular basis, but the function of these white blood cells is important. We'll talk more about it in the immune system, but I do know that there was an NCLEX test on frequency at which you find white blood cells in the body. And there's a mnemonic for that. And we'll go over it in a second, but neutrophils. Oh, no, go back. Come on, pen. Neutrophils. All right. Neutrophils are the most common or frequent white blood cell you're going to see in the bloodstream at all. They're like your EMTs. They're first on the scene when a pathogen enters the body, okay, or an antigen the body's never seen. So they're first on the scene. They're going to wage battle. They're going to call for help, get all the other white blood cells to come to the site. You will see these elevated in people who have infections and even chronic inflammation. All right. So 50 to 7% of your white blood cells, that's them. Okay. This thing right here with the pink or orange granules are called eosinophils. And I will bring up this, you see with chronic inflammation, sometimes infection, but I'm going to underline the most important things they do, allergies and parasites. Okay, you'll see these increased in some people with asthma. Not all asthmatics have leukocyte-mediated inflammation of the bronchioles because there's different types of asthma. Some people do, and the medications to treat it often target eosinophils because they can lead to that inflammation that narrows the airways. But if someone's got chronic allergies, you're going to see these elevated. If they have parasites, and that's actually something you can look at in the blood to see, oh, have you traveled recently to another country, or if you've been exposed to parasites or something like that, because you're going to see that. Okay, these things right here with the dark bluish blackish granules are called basophils. All right, they produced histamine. I'll put here, AKA means also known as mast cells. Did I bring that up before? Yeah, I think I did. I talked about Dr. Pryor. We went fishing. He got stung by a bug and he had an anaphylactic reaction. That anaphylactic shock. That's when we talked about it. Okay. Mast cells, these cells produce the histamine for your allergic reactions, and then the severe life-threatening allergic reaction, anaphylaxis. That's them. Okay. Okay. Now these cells are called granulocytes because they have granules. See these staining things? You can see them. Those little flecks. Those are granules. Now the cells that don't have the granules are called agranulocytes. The A means absence, and then granules. Okay. So this thing right here is called a monocyte. All right. Don't see it very frequently. Phagocytes. We talked about phagocytes back in the cell transport chapter. Do you remember what a phagocyte is? It eats pathogens and things like that. Yes. Phago means eat and cyte means cell. It eats. It endocytizes. It engulfs by endocytosis and destroys pathogens. And I'm just going to put pathogens, but it could be dead cells, things like that, or tissue that's abnormal. Okay, so they're important. All right, they're protecting you. This cell right here is very important, the L, lymphocyte. Make sure the L comes through. And to tell a monocyte and a lymphocyte apart, the monocyte is huge compared to that. The nucleus, which is this big kidney bean shaped thing here, takes up only about half of the cell cytoplasm, which is the fluid component right here. So it's kidney bean shaped, half moon shaped, however you want to call it, and it's large. A lymphocyte, the nucleus takes up almost all the cytoplasm, and the nucleus is round. All right. Lymphocytes are present in a pretty high frequency, second only to neutrophils. Now, lymphocytes are defense from pathogens. Your immune system is all about, well, yeah, lymphocytes. In anatomy, did you cover blood anatomy? Did you cover blood cells? How to identify them? Things like, no. Okay, when we get to the immune system, I'll talk a lot more about this, but B cells become plasma cells. These are the things that produce the antibodies. So when I was talking about blood typing, and I was talking about those antibodies, if you're type A, you have anti-B antibodies, these cells are making them. Okay, now, anyone know anything about HIV? Gonna have to know about it in nursing because you think, oh, they got people are surviving HIV now. We don't need to worry about that. It's still out there, and the virus is mutating, making it more difficult to treat. But it is still out there. Yes, the medications are getting great, and you get the PrEP now. You could take this once a week tablet, and your viral load goes down to undetectable. That's great. Okay, but it doesn't always work for everyone. So, do you know anything about T cells and HIV and AIDS? Anyone? Yes, T cells get destroyed by HIV. Okay, T cells are, I don't know what that was. Yes, yep, they activate B cells. If T cells decrease, no immune system. Okay, HIV attacks T cells. When they fall below this bare minimum, you have now gone from having HIV to having AIDS. HIV means human immunodeficiency virus. You've got the virus in your body, and it can lie quiet for a while and then become activated. It can go on for 10, 20 years. And then in that time, it's been attacking your T cells and you're losing them. And someone who has HIV, this is one thing you're monitoring. So you have an HIV patient come along, you're going to keep track of those T cells with those visits, right? Blood test, blood test, blood test. If they're losing T cells and it falls below that threshold, they've now gone from human immunodeficiency virus to acquired immunodeficiency syndrome, AIDS. Their immune system is now not working because you need T cells to activate B cells. If you don't have T cells, you aren't producing antibodies to anything. Okay, does that make sense? So are these relevant to nursing? Yes, it all is. Okay. Okay, leukocyte disorders. I assume the clinical app is working. Okay, the term for when white blood cell count is increased, and that implies an infection is brewing, is leukocytosis. So if someone blood panel, there comes back and their white blood cells are elevated, they've got an infection brewing. That might be time for them to get some antibiotics, because if you don't treat an infection that has spread to the bloodstream so that you can detect, well, has caused your immune system to mobilize its white blood cells in defense. You ignore that, and eventually there's so many bacteria, they produce so much toxins that enters your bloodstream, and now you have sepsis, right? So, okay. Let me get the diagram here. Leukemia. A friend of mine's kid just got diagnosed with leukemia, and it's tragic. Leukemia, you have an increased number of white blood cells, but they're immature. They're immature. So a medical technologist or a pathologist would get the blood sample or the bone marrow sample, and they'll make this decision or diagnosis, not you, because they look at the cells and say, oh, they're white blood cells, but this looks like a monocyte. This looks like a neutrophil. That could be the eosinophil, maybe another monocyte. Hard to tell. Okay, see these cells? They're immature. They have not become differentiated. A mature cell that leaves the bone marrow has a nucleus and clear cytoplasm. This, I don't know what the hell that is, but it came out and it wasn't cooked yet. And those immature white blood cells, since they're immature, can't protect you. We're squat. They're not going to function. All right. So that's what's going on with leukemia. Yeah, white blood cells went up, but it's immature. It's like the bone marrow pumped them out before they were ready to. Leukopenia, sorry, is the term for a decreased white blood cell count. That can happen with someone who's on chemotherapy, right? Chemotherapy, because that targets rapidly dividing cells, or immunosuppression. What happens if you have a patient that has, I know I keep going to, let's say they have myasthenia gravis, which is an immune attack on your receptors on your muscles, right? Or you have Crohn's disease, or you have, there's so many immuno disorders out there. I could list off a bunch of them. One of the ways to treat people with basically autoimmune disorders is to give them an immunosuppressant to slow the immune attack on their tissues down. Pros, you slow down an autoimmune disorder so it doesn't cause complete destruction. Like myasthenia gravis, you don't want to let that go untreated. It's destroying acetylcholine receptors in your body. All right, you got to slow it down. All right. Con, you're immunosuppressed. Your immune system is suppressed. You're vulnerable to colds, flus, COVID, you name it. All right, but stop the immune disorder, or all right. So it's pros and cons, but leukopenia. Okay, platelets. Don't memorize that, okay? But clot formation, you need platelets to form a clot. So if you cut yourself and it keeps bleeding and bleeding and bleeding, you've got a clotting disorder or something else, all right? Because platelets, so thrombopoietin right here, all right, is a hormone from the liver and kidneys like erythropoietin, but this is thrombopoietin. And that will stimulate platelet production by your bone marrow. So here is a slide of red blood cells, and those little purple stain things are the thrombocytes. They're very, very small, okay? But you need those to form a clot. And this hormone can stimulate the production of those cells. Now, I once asked Dory Weaver, who came and spoke to you, what do you want students to know about white blood cells? And I covered the things that she wants you to know. But she said clotting, okay, clotting. So it's in the textbook. So we've got some corresponding reading material. I've got a clinical app on clotting and anticoagulants, but basically hemostasis. Now there's physical hemostasis, like clamping off a bleeding artery, right? But your body tries to do it too. When you have a cut in an artery, not a major one, like if your aorta is sliced or ruptured from an aneurysm, the body's going to try and contract down on the artery, but it's too big. But your smaller arteries, they will contract down to limit blood flow through them. And then thrombocytes, platelets will rush to the site of the cut. This could be even a cut in your skin. Okay. Here's red blood cells escaping from the injury. Here's platelets rushing to the site. Here are platelets right here, purple things. And then the red blood cells are the red things. Platelets produce fibrin threads that stitch the wound together. They hold blood cells together in a clot, and they will hold the torn pieces of the tissue together. It's like stitching the wound together. That's what they do. Okay, so that literally is what all those threads are, just tying everything together, and the bleeding hopefully stops. So a blood vessel's damaged, a smaller one. All right. Arteries can constrict, so they do that. Platelets form a plug. Okay, plug. The platelets convert a slight pathway, prothrombin to thrombin. The thrombin activates fibrinogen. That's the word fibrin in it. Fibrin are the threads. Fibrinogen converts fibrin into fibrin threads, and that's these bluish teal, whatever color these threads are. That is the thread that's holding the wound together and stopping the bleeding. So, some common clotting disorder tests. People who have diabetes, have you heard this? They don't form clots very well. You know about that? It's true. Okay. But there's also some other disorders too. You can simply, with a lancet like we use in lab, okay? Probably none of you had the bleeding last for more than 5 minutes, right? Probably stopped right away. I mean, 30 seconds, a minute, it's okay. You're fine if you put a little pressure to it, right? But if it keeps bleeding and keeps bleeding, all right, longer than 3 minutes, I'd say longer than 5 minutes, that's not right. That should clot with the fibrin threads. You can also do a more fancy test called prothrombin time, treat the blood plasma, the liquid portion, with citrate, thromboplastin, add calcium. You don't have to memorize this. Okay. I do want you to know about it, but I'm not going to test you on them. But Dory Weaver would like you to know them. And if the clot doesn't happen in less than, if it's less than 12 seconds, you're fine. But if it takes longer, clotting disorder. All right. Okay. So I covered that. This is where we kind of end. And I just want to give you a little introduction because this is what you're going to be doing on the daily as a nurse. Nurses collect blood. I mean, doctors can do it too, PAs too, and all that stuff, but really it falls on you guys. So get good at it. Okay. Not every patient's going to have veins as good as mine. So get used to it. But what you'll do to collect that blood, let me get this out of the way again. Maybe way down here. Okay. You're going to be using vacutainer tubes. Okay. So that is well, these are vacutainer tubes. This is a vacutainer hub that the needle goes onto in a sterile packet. Okay. And then you put the tourniquet on their arm to get that vein to pop up. All right. Then you insert this needle into that vein. If you see blood dripping out the needle in here, you know you've hit the vein. And then you pop on the vacutainer tube. It's got a vacuum in it. It's got a rubber stopper. You punch that stopper into that needle and the vacuum, that tube will feel like this. And then you can put another tube and you can collect blood very quickly that way. All right. For your blood tests. So how many people have had their blood drawn? So you've seen it, right? They don't usually do it with a needle and syringe anymore, right? No, they use vacutainer tubes. So common tubes, the red top right there, has no anticoagulant in it. So the blood that you collect, if let to sit on a rack in a fridge, it will separate. The red blood cells, which are heavy, will go to the bottom, and then the plasma will float to the top. Okay, it's actually serum when there's no anticoagulant, and you can use that serum in serological tests. Like, a serological test could be testing for, well, COVID's come so far, but you can use that for. We used to use it in the vet clinic for testing for, heartworm and things like that, and other things and other diseases. Purple top, very, very, very common, has EDTA anticoagulant. All right. So with the anticoagulant, you can keep that blood whole because even if it settles down, you simply twist the tube around and it mixes again. So you can use it for whole blood. You can spin it and get plasma. You can use it for blood counts, which now you run through a machine. Certain diseases you'll test that way. And don't worry about the likelihood. How about just those two? But you have different tubes, like this one right here would be if you want to do a clotting test. The green one has another anticoagulant in it. And there's like a lot more tubes than this. There's probably like 10 or 12 of them. All right. And in nursing, you'll learn them all. And which is the time to use them. So with that, we're done. Now I'll post these notes today. We'll have the quiz on Friday. Yes, ma'am. Let me hear her question here. Hold on. When they have what? Bed sores and stuff like that. Oh, well, okay. She asked, why don't you have a clot formation when people have bed sores? Well, they do. If you turn them enough that they get their pressure point where the sore is forming, you're supposed to turn them regularly so their body is not sitting on one pressure point for too long. Christopher Reeve, an actor, he died from bed sores because he was paralyzed, right? So yes, it does, but if you don't turn them enough, the abrasion, everything keeps happening. All right. And then bacteria get in and the body is trying to heal itself, but as nurses, you're going to need to remember to turn people enough. All right. So the sign-in sheet went around. I sent around a thank you card for people who took the CPR class. If you did not get to sign it, please do so before you leave, and I'll see you Friday. Yeah, right there. Yeah. Yeah, it's right there. It's right there. Here, you can write on this. Right there. Thank you. I do appreciate that. I know they will appreciate it. You too.
You never said that. You know, her husband. Oh, okay. She said your husband's fertilizer. Oh, okay. Yeah, I'm gonna buy the cheese. Right. I'm gonna say you gotta sign up for it. You don't have to sign up. No. He got his job.
Yeah, I went and looked, as sign up sheet and it's empty, mostly empty.
I have one today, so they're basically like making you a fake schedule.
Well, or they talk to you about the schedule. Really, students supposed to make their own, but they go over, here's what you've completed, you know, and here's what you're enrolled in now, and here's really what makes sense to take next. And then, you know, if you're pre-nursing, then it's a set, you don't have to think much, all right? But they kind of say, you know, well, you should take this next for your degree or career aspirations. But they don't put the schedule in for you or anything like that. You do, you put a plan together in the portal. And when your registration opens up, you'll see a register now button, go live, and then
I think she told me before because last fall was like.
oh, I didn't, and I'm here talking, I didn't end it, and meeting